Clinical chemistry, thyroid hormones. The thyroid is positioned in the lower anterior neck and it's shaped like a butterfly. It's made up of two lobes that rest on each side of the trachea and is a band of thyroid tissue, the isthmus, that runs anterior to the trachea and bridges the lobes. Parathyroid glands are posterior to the thyroid, and their primary function is to regulate serum calcium levels and recurrent laryngeal nerves that innervate the vocal cords. So the parathyroid glands produce parathyroid hormone, and parathyroid hormone increases blood calcium levels by causing resorption of the bone. So it stimulates those osteoclasts in order to break apart bone and release calcium into the blood. Thyroid hormone is critical to neurologic development of the fetus. Iodine is an essential component of the thyroid hormone. So an iodine deficiency during pregnancy leads to hypothyroidism, mental retardation, and cretinism. Congenital hypothyroidism occurs in 1 of 4,000 live births. The thyroid produces two hormones, thyroid hormone and calcitonin. Thyroid hormone is critical in regulating body metabolism, neurologic development, and other functions. And calcitonin is secreted by the parafollicular C cells, and it's involved in calcium homeostasis. Calcitonin opposes parathyroid hormone. So I just talked about how parathyroid hormone causes bone resorption. Calcitonin is going to cause bone deposit. So that's going to decrease blood calcium levels by allowing calcium to enter into the bone. Conditions affecting thyroid hormone levels are much more common than those affecting calcitonin. So thyroid hormone synthesis. Iodine is a trace element and a key component of the thyroid hormone. It's found in seafood, dairy products, breads, and vitamins. And in the United States, we have iodized salt. So to ensure that people in the United States get enough iodine in the diet, we add it to our salt. An intake of less than 50 daily leads to hypothyroidism. Follicles, the site of thyroid hormone synthesis. Spheres of thyroid cells surrounding a colloid core. Inside the thyroid cell, iodine is oxidized and bound with tyrosine residues on thyroglobulin to form thyroid hormone. Protein binding of the thyroid hormone. So two active forms of the thyroid hormone exist, triiodothyronine, which is T3, and tetraiodothyronine, which is T4. T4 is also known as thyroxine. When released into circulation, only 0.04% of T4 and 0.4% of T3 are unbound by proteins and are available for hormonal activity. There's three major binding proteins: thyroxine binding globulin, or TBG, thyroxine binding prealbumin, TBPA, and albumin. The control of thyroid function. Hypothalamic pituitary thyroid axis regulates the thyroid hormone production. Thyrotropin releasing hormone is synthesized by the neurons in the hypothalamus and it's stored in the median eminence. When it's secreted, it stimulates the cells in the anterior pituitary gland to manufacture and release thyrotropin. Thyrotropin is thyroid stimulating hormone, or TSH. TSH then circulates to the thyroid gland and increases the production and release of thyroid hormone. The thyroid hormone circulates in the bloodstream where T4 is deiodinated into T3. T3 leads to proteins that influence metabolism and development. The effects of thyroid hormone include the following: tissue growth, brain maturation, increased heat production, increased oxygen consumption, and the increased number of beta-adrenergic receptors. In individuals who have excess thyroid hormone, thyrotoxicosis, symptoms of increased metabolic activity such as tachycardia and tremor exist. In individuals with hypothyroidism, symptoms include lowered metabolic activity like edema and constipation. Tests for thyroid evaluation include blood tests. TSH, or thyroid stimulating hormone, is the most useful. Third-generation assays used in assays that are capable of diagnosing primary hypothyroidism, thyroid gland disease leading to low thyroid hormone production with elevated levels of TSH. Serum T4 and T3 are also measured, and they can be measured by radioimmunoassay or chemiluminometric assay. More than 99.9% of thyroid hormone is protein bound. Alteration in the thyroid hormone binding proteins frequently leads to total T4 and T3 levels outside of the normal range without representing true clinical thyroid dysfunction. Thyroglobulin is a prohormone in the circulation that's proof of the presence of thyroid tissue. Thyroglobulin is an ideal tumor marker of the thyroid cancer post-treatment surveillance. Thyroid autoimmunity. So most common cause of hyperthyroidism is an autoimmune disorder called Graves' disease. Antibodies in this condition are directed at the TSH receptor, TSHR, stimulating the receptor and leading to the growth of the thyroid gland and production of excessive amounts of thyroid hormone. Chronic lymphocytic thyroiditis, commonly known as Hashimoto's thyroiditis. Antibodies lead to a decrease in thyroid hormone production by destruction of the thyroid gland, which is the most common cause of hypothyroidism in the developed world. Nuclear medicine evaluation. So radioactive iodine assesses the metabolic activity of the thyroid. It evaluates and treats thyroid cancer. So if we give radioactive iodine, iodine localizes to the thyroid, and that directly can treat thyroid cancer. Given orally, a percent of the dose is taken up by the thyroid gland. High uptake suggests metabolic activity, while low uptake suggests metabolic inactivity. Because TSH stimulates iodine uptake, TSH levels must also be taken into account. Thyroid ultrasound has become more significant in the past several years. It's capable of detecting thyroid nodules of exceptionally small sizes, like less than 1 centimeter. Fine needle aspiration is often the first step and most accurate tool in the evaluation of nodules. Routine use allows prompt identification and treatment of malignancies, avoids unnecessary surgery in benign cases. A small gauge needle is inserted into the nodule and cells are aspirated. Hypothyroidism is defined as free T4 levels with a normal or as low free T4 levels with a normal or high TSH. One of the most common disorders of the thyroid gland, occurring in 5 to 15% of women greater than 65 years old. It can lead to hyponatremia. Hypo means less. Na is the element symbol for sodium, so we're talking a decreased amount of sodium. Anemia and hyperlipidemia. So anemia is low hemoglobin or low oxygen carrying capacity of the blood. Hyperlipidemia is talking about too much fat in the blood. It can be divided into primary, secondary, or tertiary diseases. The most common cause in developed countries is chronic lymphocytic thyroiditis, or Hashimoto's disease. Individuals should be tested beginning at age 35 and every 5 years thereafter, more frequently if risk factors are present. It's treated with thyroid hormone replacement therapy. Measurement of TSH. So it should be measured at age 35 and then every 5 years after the age of 35. Individuals with risk factors or symptoms, goiter, presence of other autoimmune diseases, first degree relative with autoimmune thyroid disease, lithium use, and amiodarine use. Guidelines are from the American Thyroid Association and American Association of Clinical Endocrinologists. Thyrotoxicosis. A constellation of findings that result when peripheral tissues are presented and respond to an excess of thyroid hormone. Possible causes include excessive thyroid hormone ingestion, leakage of stored thyroid hormone from the thyroid follicles, excessive thyroid gland production of thyroid hormone, or hyperthyroidism. Symptoms include anxiety, emotional lability, weakness, tremor, palpitations, heat intolerance, perspiration, and weight loss. Graves' disease is the most common cause of thyrotoxicosis, and we talked about this earlier, but it's an autoimmune disease in which antibodies are produced that activate the TSH receptor. Features include thyrotoxicosis, goiter or swelling of the thyroid, which causes the neck to be enlarged, ophthalmopathy or bulging of the eyes and poor vision, or dermopathy. Strong familial disposition. 15% of patients have a close relative with this condition. Women are 5 times more likely than men to develop it, and lab tests show high free T4 and or T3 level with undetectable TSH. Symptoms of cardiomyopathy or orbital soft tissue swelling, injection of conjunctivae, proptosis, double vision, and corneal disease. Treatments, medications like beta blockers, radioactive iodine, or surgery. Toxic adenoma and multinodular goiter is caused by autonomously functioning thyroid tissue. Neither TSH nor TSH receptor stimulating immunoglobulin is required to stimulate the thyroid hormone production. It's associated with receptor mutations in some toxic nodules. Occurs in patients with hyperthyroidism and palpable nodules. Treatment includes surgery, radioactive iodine, or medication. Amiodarine-induced thyroid disease. So amiodarine is a medication that's used to treat cardiac arrhythmias. It's fat-soluble with a long half-life of 50 days. 37% of molecular weight is iodine. The effects, it inhibits thyroid hormone production, and it blocks T4 to T3 conversion. It leads to hypothyroidism in 8 to 20% of patients and hyperthyroidism in 3%. Subacute thyroiditis is characterized by transient changes in the thyroid hormone levels. It's associated with inflammation of the thyroid gland, leakage of stored thyroid hormone, and the repair of the gland. There's 3 classifications: postpartum, painless, and painful. Postpartum occurs in 3 to 16% of women in postpartum. Painless is similar to postpartum except with no association of pregnancy. And painful is characterized by neck pain, low-grade fever, myalgia, tender diffuse goiter, and swings in thyroid function tests. Abnormalities in thyroid function tests of hospitalized patients, especially critically ill patients, are characterized by low total T4, free T4, and TSH. Less T4 is converted to active T3, leading to a decrease in levels of T3 and higher levels of reverse T3. Central hypothyroidism and thyroid hormone binding changes are associated with severe illness. Changes may be appropriate adaptations to illness. Thyroid nodules are clinically apparent nodules that are present in 6.4% of adult women and 1.5% of adult men. Thyroid ultrasound finds unsuspected nodules in 20 to 45% of women and 17 to 25% of men. Despite the frequency of thyroid nodules, only 5 to 9% are non-palpable nodules proved to be thyroid cancer. Fine needle aspiration with cytologic examination of the aspirate is used to determine the need for surgical removal.